Hi, my name is Deric Morrison. I'm an endocrinologist in London, Ontario at the University of Western Ontario. I have had the pleasure of being the medical advisor for the Thyroid Foundation of Canada for a number of years now, over 5, I'm pretty sure. I'm sorry I cannot attend the annual general meeting, even though it's virtual this year. I have some other commitments. I do want to congratulate the Thyroid Foundation of Canada on their 40th anniversary for an annual general meeting, and on all the good work they've done with respect to thyroid disease and helping thyroid disease patients over the years. I'd like to thank Laz and the rest of the organizers for inviting me, and I am going to do my best to try and answer some thyroid questions that have been posed by members of the attendance today, and also from patients who have called into the helpline. So the first question is, what suggestions and or treatments would be appropriate for the approximately 15% of people still suffering with hypothyroid symptoms after being treated with Synthroid, or I guess that could also be any type of levothyroxine, T4, especially those with Hashimoto's and or long-term untreated hypothyroidism before being diagnosed. So I could probably spend a few hours talking about this issue. It's a significant one, but I'll try and boil things down a little bit. It's a true statement that when studies have been done examining the quality of life of patients with hypothyroidism that have been what seems to be on appropriate treatment with levothyroxine, T4, brand names are Synthroid and Altroxin, those quality of life scores on average are slightly lower than people without any type of thyroid dysfunction. The difficulty is knowing how to bridge that gap, and if there are any effective treatments that could help bring those quality of life scores back to the same as the general population. And unfortunately, at this point, there is no definitive evidence for a strategy that would be appropriate for treating those patients that would then, fix this problem. Certainly, as a physician, when encountered with this question, there are a few things that we need to think about. One is there anything else going on that could be creating the symptoms? So many symptoms of hypothyroidism can be nonspecific and caused by other problems, and hypothyroidism does put people at risk for developing some other conditions. And even just coincidentally, people with hypothyroidism could have other conditions that contribute to symptoms that could mimic those that are also caused by hypothyroidism. So the first thing is to keep an open mind and make sure there's nothing else we can address that will help with the problem. If nothing else seems to be obvious, then it's a difficult situation. We do have to acknowledge and remember that Hashimoto's hypothyroidism is a disease, and diseases and illnesses can affect quality of life. And despite the most effective treatments in some diseases, right now in 2020, with what we know, we don't always have the ability to completely bring a person back up to the level of functioning they had before the disease was developed or compared to healthy controls. This is true of Hashimoto's hypothyroidism. It's true of other endocrine diseases like Addison's disease, type 1 diabetes. All of these can impact quality of life, and it's important that we acknowledge that. In thyroid disease, sometimes there isn't that acknowledgement, and it's brushed off as being not as important. That doesn't help with the symptoms, though, and unfortunately, again, there's no real evidence of what the best adjustment to treatment should be. In some cases, it might be reasonable to try and optimize the TSH into perhaps the lower half of the normal range, and that might help with some people who are still having symptoms. It is never really a good idea to be increasing the thyroid hormone dose to a point that the TSH is low, because we know that can cause medical issues, dangers to the bones and the heart down the road. And there's no evidence that it will fix the problem we're trying to address, which is the ongoing symptoms. There has been a number of studies that have tested combination therapy with T4 and T3, and the short answer is we don't know if there's an optimal combination therapy that will address these kind of symptoms in some patients. For most patients, levothyroxine alone is the standard of care and the best treatment. In certain situations where there's no other obvious explanation for symptoms and a patient is enthusiastic on trying an alternative approach, it may be reasonable to do a trial of a combination of T4, the levothyroxine, and T3. But there are some important things to be aware of. The fact that T3 has a shorter half-life and the levels can go up and down. You probably need multiple daily doses of T3. And getting the right proportion of T4 to T3 is difficult. I think there's a question later on about desiccated thyroid hormone, which is dried pig thyroid, usually, can sometimes be other animals, I guess, as well. But the proportion of T4 to T3 in a desiccated thyroid hormone pill is much higher weighted towards T3 than is present in a person's blood who has a normal functioning thyroid gland, where the range is about 14 to 1, as opposed to pig thyroid, where the production of T4 to T3 is about 4 to 1. So there's a bit of an imbalance there. Again, this is a bit of a long discussion already, and I'm not sure I can go over all the issues and do it justice in a short video, so perhaps I'll leave it at that. More specific information would probably have to come from your own healthcare providers. Okay, question 2 I think would be a little bit more straightforward. So someone noticed that there's mention of antibodies when referring to research being done now with the COVID-19 pandemic. And is there any relationship at this point, presumably, to thyroid antibodies? And the short answer to that is no. So outside of the fact that the immune system is responsible for creating antibodies to whatever the stimulus for creating that antibody or antigen is, in one case it would be COVID-19. In another case, the body mistakenly creates antibodies to the thyroid, causing Hashimoto's and hypothyroidism. But those types of antibodies really have no relation, and there's not really a connection there with thyroid antibodies and the immune response to COVID-19, which would be producing antibodies. Question 3, I'm not sure I can help with. There's a mention of a new kind of thyroid disease identified. I'm not really sure what that's referring to. I don't think I can really answer that. Question 4 was, does thyroid medication affect heart medication? And related to that, what is desiccated thyroid hormone? And is it safe for people taking heart medication? There's a suggestion that some data suggests it should not be taken by people over age 65. So I think we already talked a little bit about desiccated thyroid hormone, and the concern here is that that higher proportion of T3 with a shorter half-life could result in higher thyroid levels for part of the day, or just over treatment with thyroid hormone in general. And one of the effects of thyroid hormone is to increase heart rate, increase the pumping power or stroke volume of the heart. And so higher thyroid levels could potentially put strain on the heart. And for that reason, it's been recommended that people who are at risk for heart disease, and older people are more at risk than young people, perhaps potentially not take desiccated thyroid hormone or strategies that contain T3 in higher doses, because there is theoretically more risk of having times during the day or overall more thyroid hormone than is necessary. The next question is about trying to get thyroid hormone levels to a point where one feels well. I think a lot of this discussion might have occurred around the first question. The other part to this next question was, do I have to be referred to an endocrinologist? I mean, I think, you know, that's an option. I think that, as mentioned before, it's important to make sure that there's no other reason that's causing the symptoms. And then as far as the potential for alternate strategies, such as a combination of T4 or T3, it may be that some family doctors would provide that, but more likely, I think, they would feel more comfortable having that supervised by a specialist. And so that is, if that's an option that's on the table, a discussion with an endocrinologist often might be reasonable. I think I've addressed the rest of the comments in that question. I'll move on to the next. This is an interesting and timely question. Are there any medications one should avoid? Specifically, this person remembers going to an American Thyroid Association session being told that biotin can affect laboratory results. So biotin is a B vitamin. It's been marketed recently in doses that are about 1,000 times the daily requirements for this vitamin to potentially help with hair growth and skin and nails. I think fingernails. Sorry, more so than skin. You know, not sure about the details of the evidence of how effective that is. In general, probably not harmful unless it's expensive and harmful to your pocketbook. But there are a number of people that are trying this supplement to help with hair and fingernail qualities, which are, of course, things that can be an issue in thyroid disease. So the biotin doesn't do anything that we know of harmful to the thyroid, but what's interesting is it is a molecule that is a part of the chemicals in the testing of thyroid hormone. So it can make the TSH in particular inaccurate. So they draw your blood, it goes into the test tube, there's a normal amount of TSH in there, but when it goes through the test, the biotin messes things up and it actually usually makes it look like there's not enough TSH. So that can be a problem if we don't know that that's the reason. It can easily be avoided by stopping biotin probably for as little as a couple of days before the blood test. Usually I tell people for about a week, just to be sure it's out of the system. And then if one chooses to use it when they're not getting lab tests done, it shouldn't have any effect on the thyroid. The next question relates to this, asking about soy and soy-based products being safe to take with thyroid medication. And this is another way that thyroid levels can be influenced by drugs or foods, and that's really with the absorption. So there are some theories out there about soy being more related to how the thyroid functions. I don't think there's any direct evidence of proof for that, but what we do know is that foods can inhibit the absorption of thyroid pills when you take them. So it doesn't do anything to somebody's thyroid it's working normally, but if you take a thyroid pill and eat a bunch of soy, it might not get absorbed. It just might pass through without getting into the bloodstream. Same is true, and even more important, likely with dairy products, things with calcium in them, or calcium supplements, which can really bind up the thyroid hormone and not allow it to be absorbed into the bloodstream. So to optimize the absorption, it's ideal to take thyroid hormone on an empty stomach, usually wait about an hour before eating, if possible. And if there's any calcium supplements or other minerals like magnesium or iron or things like that, to try and wait about 4 hours before taking those doses. Now, the most important thing, though, is to make sure that you can adopt a consistent routine. So if that 4 hours is just not going to be realistic, if you can wait 2 hours or even 1 hour, but do it the same way every day, that's better than, you know, sometimes missing pills because your routine is too complicated. Also, there's no one time of day that's better to take thyroid hormone. So some people find it easier to separate it from other things in the morning, some people at bedtime, or maybe some other time of the day. As long as you can take it the same way, a good routine, and try and separate it as much as reasonable from other foods and supplements is the idea. The last question, a little bit different, is are thyroid patients more likely to develop arthritis, and is there any correlation between the two? Well, yes, there is. So thyroid, Hashimoto's hypothyroidism, the most common cause. The other sort of common cause, less so, but would be, removal of the thyroid or damage from radioactive iodine treatment, which would be different because those aren't necessarily autoimmune related. But for autoimmune Hashimoto's hypothyroidism, which is by far the most common cause, rheumatoid arthritis is another autoimmune disease. And if you have one autoimmune disease, you might be at risk for developing another. That risk is not that high, and most patients with hypothyroidism don't get rheumatoid arthritis. Untreated hypothyroidism can cause muscle aches and pains, but not really joint destruction or physical changes with the joints that you'd expect in other types of arthritis. So that should be reversible once the hypothyroidism is controlled and the TSH is back in the normal range. I hope that has been helpful. And maybe longer than you were hoping, and it's okay if you cut it off partway through. Again, I apologize that I couldn't be there live, but again, would like to congratulate you on this event and the 39 that preceded it. Thank you.